Since the development of the currently known immune checkpoint inhibitors and targeted therapies, we have seen the prognosis of patients with advanced melanoma increase. However, still about half of patients don't have durable responses on these currently approved therapies, so there's a need for the development of novel treatment modalities. In earlier phase 1-2 trials, treatment with adoptive cell therapy with tumor-infiltrating lymphocytes have shown encouraging results. And this was confirmed in a recently completed multi-center phase 3 randomized trial conducted at the Netherlands Cancer Institute and the National Center for Cancer Immunotherapy in Denmark. And in this trial, patients were randomized for either TIL therapy or ipilimumab. And we were interested for TIL therapy. Patients had to undergo a metastasectomy for the retrieval of TIL and the ex vivo expansion, but it was unyet known what the impact of location and size of that metastasectomy was on clinical outcome or the produced cell numbers. So in this abstract and this trial, we looked into that impact of the size and location of that metastasectomy. And we looked into the patients that were randomized for the TIL treatment in this randomized phase 3 trial. And of those 84 randomized patients, 80 received TIL. And the median time from randomization to metastasectomy was 10 days. And in 10 patients, we also had to perform a second metastasectomy due to insufficient initial outgrowth of the TIL. In the end, we had a very high success rate of TIL manufacturing, with 99% of patients for whom production was started was successful, and we infused a median number of 40.9 billion cells in the 80 patients that were treated. Of those patients, the majority underwent either resection of lymph node metastasis or a subcutaneous metastasis. But we also saw that 11 patients underwent resection of a visceral metastasis, mostly lung. But we saw in this project or this study that the location of this metastasectomy had no impact on clinical outcome or on resulting cell numbers. When we looked further into the size of the metastasectomy, we either had patients where we resected one lesion that was at least 2 to 3 centimeters in size, or more than one lesion that in total comprised 2 to 3 centimeters. We also did not see any difference in resulting cell numbers in either group. So this shows that the location and size of the metastasectomy had no impact on clinical outcome or resulting cell numbers, and that TIL is a robust treatment option, possibly for this patient population.